I want to go ahead and introduce Dr. John Hick from Asper Tracy. Dr. Hick is an emergency physician and the lead editor for Asper Tracy. He's going to go ahead and share a demonstration of the DASH tool. I know that I had reached out to the council members here to gauge the level of awareness and utilization of the Asper DASH tool. And based on that, we're working with Dr. Hick and some other team members to raise the level of awareness and utilization. The poll response, the quick pulse poll response, came back rather low regarding awareness and utilization. So we're hoping to change that trajectory here with this presentation today. So without any further delay, Dr. Hick, let me go ahead and turn the floor over to you. Thank you.
Great. No, thank you, Mike. Really appreciate this opportunity to be with you and all of our stakeholders today in the midst of, as usual, another very busy fall. I'm just going to try to share my screen here, and I don't think I've got anything embarrassing pulled up on my screen. So we'll take a look here and see what we got. Sorry, Teams is prompting me to do all kinds of updates and stuff, so we don't need that. All right, let's see how.
There we go.
Let's see how we're doing. Can you see that okay?
Yeah.
All right. So I just want to, start off by thanking Healthcare Ready and HIDA that were two amazing partners along with a lot of subject matter experts in developing the DASH tool. So the DASH tool is the disaster available supplies in hospitals. And I just want to take the next about 10 minutes just to kind of explain what it is and walk through what it does. So we've gotten a lot of questions over the years about what should my hospital have available in case of a disaster in my community. And the DASH tool is designed to try to answer that question based on the characteristics of the facility in a variety of different domains: hospital pharmacy, personal protective equipment, burn supplies, and trauma supplies. And the request actually came from the University of Nebraska and was designed to apply to a diversity of different types of hospitals. So I just want to walk through and show you a little bit about what this tool can do. This tool is really designed to answer the question for the 90% of disasters that might occur in my community in these different categories. What do I need to have on hand? So in the hospital pharmacy module, and it's really important, there is quite a lot of assumptions that are built on the back end of this. And so there's instructions about how to use the tool here in PDF format. There's also instructions about our methodology. Basically, what assumptions did we use in designing this calculator that people need to kind of understand, honestly, in order to make good use of the outputs. But we'll kind of jump right in as usual, when you're using a chainsaw or whatever, we're going to bypass that and go right here. So this is basically the initial assessment of the hospital for pharmacy. So we're going to say that we're a level 2 trauma center. We're going to choose our emergency department beds, which does not really create any issues with the calculation for level 1s and level 2s, but the smaller trauma level, the lower trauma level the hospital has, we do tie that a little bit to the size of their emergency department to try to calibrate against what role that hospital is playing in the community. We don't provide inpatient burn care. We're not transferring patients to other trauma centers because of our trauma level. We're not at disproportionate risk for shared burn or trauma patients in our community. But if we were the only level 1 or level 2 in a region, we would definitely check that, and that would increase our requirements by 50%. You'll see that change here as I choose yes for this answer. And basically, the bars will increase on the right-hand side, but we're going to revert that back to no. And our natural disaster is likely to isolate the hospital for days or longer. And again, especially in a small rural hospital, this would be a particular issue. So with our information set here, we're going to go to the index. And so these are the different categories of different medications. And my hospital pharmacist said that in total, it took about 2 hours to do this. But you can do this, sit down and do a couple categories and then come back the next day and do a couple more. But let's just look at injectable analgesics here. So we've taken from our supply chain partners as well as hospital pharmacist SMEs, the most common preparations for all of our different pharmaceuticals, and basically put them in so that we can populate this with, say that we really use a fair amount of fentanyl here and quite a bit of ketorolac. We use quite a bit of hydromorphone, and we also do some pain control for cancer patients. So we've got quite a bit of morphine for PCAs available too that could be diluted down. That kind of jumped up there a little quickly for me. But you can see how as I populate this, this is showing me the different contributions of each of those against what our target is to supply the pharmaceuticals for the first 48 hours for patients under our care during a trauma or critical care event. So this can be, you can do a bunch of these and you can export this to PDF and basically illustrate, for your supply chain partners or your hospital leadership team, where do things stand for us as relative to what we think we ought to have available. Because of the Ebola situation in Uganda right now, there's a lot of questions getting asked around how much personal protective equipment should we have available. And that's an excellent question. So again, we have the instructions and the methodology for PPE. And again, those assumptions are really important to understand, but for the sake of time, we're going to bypass those a little bit here. There's 3 different modules under PPE. You can either look at the PPE for viral hemorrhagic fever, for special respiratory illness, similar to SARS or MERS, or for pandemic calculations. And we really allow a minimum of 6 months for pandemic calculations and allow a variety of assumptions about reuse of respirators, use of reusable versus disposable gowns, use of elastomeric respirators and other things that may contribute to a reduction in disposable N95 respirators. So there's a wealth of information here, as well as opportunities for the hospital to tailor this. But for the sake of currency, let's just take a look at viral hemorrhagic fever. Let's say that we're an assessment hospital, so we really want to plan on having 2 days of PPE available. We're only going to staff 1 isolation room, although we could take more of 1 patient at a time in that room. And we're going to use gowns instead of coveralls. Let's say that we're using N95s instead of PAPRs. If we do select PAPRs, we need to specify whether components of that PAPR are disposable or not. So it's really important here to decide based on what our level of care, how many days we think we need to be planning for. So then we can go on to the next here. And now this gets into our staffing. How many staff are going to be in the room at one time? How many room entries are we planning for across a 12-hour shift? And that will generate quantities of PPE needed then across those shifts and by the day. So we can change this here if we are not allowing environmental services staff, for instance, into these rooms and having the nursing staff do the daily cleaning aside from a terminal clean. We can adjust these variables here to 0. If the nurses are drawing the labs, we can adjust lab tech staff to 0. And if we want to change the number of room entries, we can change that as well. So there's a lot of possibilities here to modify based on what our staffing and plans are for use of PPE. So this basically generates the totals that we're going to see for each category of person entering into that room over the course of 2 days. And then we can basically get our totals here, the grand totals that you see at the bottom for the total number of gloves, gowns, N95 respirators, et cetera, that would be used over the course of those few days. If you are a treatment center and are planning for a much larger number of days of PPE, for example, let's say 14, and you've worked with your supply chain partners, this should recalculate here. And you can see that this is, with new calculations, we're seeing much, much higher numbers of gloves, gowns, and respirators that would be required. So this allows you to, pretty quickly in real time, look at some of the assumptions and based on what you are concerned about with supply chain potentially, or your role in the community, make adjustments. For burn supply, again, it's going to be very important to take a look at those assumptions and really important to work with your regional burn planning partners because some burn centers are pretty specific about the type of topical dressings that they want used. But we offer a variety here in consultation with our American Burn Association partners that allows you to do a variety of different things in providing that initial burn care and hopefully covers most of the waterfront. So let's say that we're a level 3 trauma center here, so more of a community center with 30 emergency department beds, so pretty good sized. We don't provide inpatient burn care. We're not the receiving center for burn patients, and we're not likely to be isolated. So at this point, we're preparing for 15 burn inpatients, or basically a 40% body surface area burn, and 45 burn outpatients with less than 10% body surface area burn. So the first thing we've got to decide was what to put on that burn. So there's a variety of topicals we can choose here, from bacitracin to mafenide, which is more designed for third-degree burns, to silver sulfadiazine, and a variety of different product quantities and weights. So if we're fortunate enough to have a bunch of 1-pound jars of bacitracin, which are pretty tough to find, you can see that already we've exceeded what we need to have for that number of patients. But we also want to make sure that we've got some degree of each of these topicals for different types of burns and situations, because there are definitely preferences for certain situations. So we are allowing about 40% of that quantity to be flexible and allow the hospital to choose. And then we're locking in about 60% to make sure about 20% of each of these is represented in the hospital formulary. So we'll put in a couple values here and make sure that we can get up to that point.
Dr. Hick, quick question for
Yes.
you. Would you prefer questions as you're going through the presentation, or would you rather those are saved to the end of the presentation?
Oh, great point. Yep, probably wait until the end, Mike. I'll just move pretty quickly through these modules here, and then we should have some good time for questions. So
Perfect. Great. Thank you.
So we'll just finish up with the burn module and go on to the trauma module here in just 1 minute. So after the topicals, we have to decide on dressings. And so there's an option here to use a petrolatum impregnated or silver impregnated dressings, Xeroform. Really kind of depends on what the preferences are for the hospital. The other option is to use a sterile burn gauze dressing that's directly applied to the topical. That obviates the need for an absorbent that's placed over the adaptic and petrolatum. So if we wanted to do something like that, and because those are sterile and packaged in a dry format, they don't tend to go outdate very quickly. So let's say that we've got 20 of those available. We'll have a bunch of adaptic 5x9s. And again, this is calculated based on a 40% BSA burn, about 40 Xeroform. And again, you can see the quantities populating up to what we need to get to. Right now, we're a little bit short, but that's okay. I just want to go on to show that because we're using some Xeroform and petrolatum, we do need to have bandages. And so if you use tubular elastic net, that's included here. Or if you're using Curlex fluffs and roller gauze, that's included as well. There is a requirement to have some absorbance here because we are using adaptic and Xeroform as our base rather than a absorbent dry sterile burn gauze. So we would populate those quantities. There's additional inventory needed here for debridement. There's also saran wrap recommended in case of a crisis situation. That plus bacitracin can make a good, very temporary dressing, sterile burn sheets, head covers, etc. So there are definitely some overlap between what is needed within burn as well as trauma. So we have generally confined those to one module. So these are complementary modules. So scalpels that might be needed in burn treatment are included in your trauma supplies. The trauma supply output is actually relatively straightforward because we're really basing this on the hospital trauma level and your role in the community as a single center or other major centers in your area. So in consultation with the American College of Surgeons, we came up with some recommendations by each trauma level here. We'll again choose a trauma 2. So we're preparing for 50 seriously injured patients at this time. Again, very important to remember this is for serious injuries. So we've got a couple different tables here for respiratory supplies, including pediatric supplies. You can see that these variables are multiplied by the total seriously injured patients to get to the quantity needed. So we're assuming, a 50% level of intubations here, plus intubations for children. A variety of different endotracheal tubes, et cetera, backup airways. And then we move into IV supplies and IV access. And finally into dressings, wound care, musculoskeletal, et cetera. So these can be printed out and surgical supplies. These can be printed out again as PDFs and compared to inventory within the emergency department as well as within sterile and central supply to make sure that there are adequate supplies on hand. And again, these supplies are increased if the facility is at risk of disproportionate number of casualties or is at risk of being isolated, in their community because of a natural disaster, cutting off roads, et cetera. So I hope that gives you a bit of a flavor for this tool and an idea about how robust we feel that this is relative to driving assumptions about not only on-hand supplies, but also conversations regionally about the need for caches for burn supplies within healthcare coalitions, and also discussions with supply chain about availability and limitations of backfilled supplies. So with that, Mike, I'll be happy to take any questions that people might have about the tool.
Well, Dr. Hick, thank you so much for that presentation. I know you covered a lot of material in a short period of time, so I'd like to open it up to the council members here for some questions. Bob, I know you had your hand raised first, Bob. Bob Byer.
I did. Yeah. So thanks for the presentation. Looks like a really nice product. Just a question: when you did the PPE, it just came to my mind. And if you said this, I'm sorry I missed it. But like something like N95s, does it make assumptions on the or I think there's a variety of ways people are using N95s, but does that make an assumption of a full day's use? Does that make an assumption of throwaway after one-time use? Any type of assumptions like that? How are those built in?
Yeah, that's a great question, Bob. We worked with our NETEC colleagues on this. So the assumption for both the viral hemorrhagic fever and special respiratory pathogen module are that the N95 respirator would be disposed of after each room exit.
Okay.
The assumption for pandemic is that the N95 will be used for the duration of the shift, and that is a variable that can be adjusted by the hospital or by the healthcare system if they wish to, plan on using those longer or shorter periods of time. I think that's very helpful then for the hospital to be able to sit down with the leadership team and say, these are the assumptions we're making about our N95 use during a pandemic, and this is how many months that this will give us based on those assumptions. If we change the assumptions, here's what that yields in terms of durability of supply, and here's where we stand in relation to costs. So that's the only module in which you can vary the assumption about N95 respirator use.
Okay, perfect. Thank you.
Okay, I see Melissa Boyles.
I had a question along the same lines in the PPE when you were filling out the N95 versus the PAPR. Are you able to choose both of those? Because I think we have a mix, right? Depending on whether someone can fit test or not.
That's a great question. So for we ask you to specify a preferred for both the viral hemorrhagic fever and for the special respiratory pathogens. For the pandemic, you can give an estimate of the number of your providers who would be covered by PAPR or elastomeric respirators, and then we'll calculate the remainder of the staff needing N95 disposable respirators. But generally speaking, when hospitals are training special pathogens teams, the basis for that tends to fall on either a preference for the PAPR or a preference for N95, which is why NETEC recommended that we give either option.
Thank you.
Sorry, I can't find a me.
Did that help, Melissa?
Yes, thank you.
Great. Other questions for Dr. Hick? Feel free to unmute yourself and ask.
Mike, I don't know if you saw this in the chat, but someone wanted to know if they were able to share this information with their chapters. So Dr. Hick, are you comfortable with this going out to a larger group of supply chain professionals?
We very much welcome feedback on it. If people notice, as someone did early on, there was a calculation error that was occurring. We're really grateful when those are pointed out and we can rapidly correct those, as well as if there's suggestions for how we can improve the tool in the future. We're always open to those as well. So there's an opportunity to provide that feedback listed on the homepage.